Welcome everyone to the state partner call of the Rural Healthcare Provider Transition Project. This project was created and funded by the Health Resources Services Administration, Federal Office of Rural Health Policy. I'm Sally Buck, the CEO at the National Rural Health Resource Center, and the center was awarded the 5-year cooperative agreement to assist small rural hospitals and certified rural health clinics in strengthening their foundation for value-based care through technical assistance supported by the Federal Office of Rural Health Policy. And we have invited state partners, including state offices of rural health, flex programs and SHIP programs, quality improvement organizations, rural health associations, and rural health clinic associations through their work with small rural hospitals and clinics in their state. We'll go to the next slide, please. Just background on that. The center's purpose: we are a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. And as the nation's leading technical assistance knowledge center in rural health, we focus on these 5 core areas, including the transition to value and population health, which is where this project really resides, collaboration and partnership, performance improvement, health information technology, and workforce. And in late in 2021, the center adopted a diversity, equity, inclusion, anti-racism position, and this was developed by our staff and embraced by our board and staff, that we are committed to DEI and anti-racism, really working to create an environment that reflects the communities we live in and we serve, in a place where everyone feels accepted and empowered to be their full authentic selves and where everyone belongs. And through this work, we are embedding DEI and anti-racism into not only our communication and technical assistance programs, and you'll be hearing about some new aspects of that in our work with the hospitals and clinics, as well as in our overall technical assistance this year in some of our programming. So in today's call, we will be talking about the role of state partners, providing a technical assistance overview of RHPTP in year 2, provide some update of the year 1, the previous year's outcomes from hospitals and clinics that are participating. We'll hear from Stratus Health, who is our quality improvement contractor, providing an update on some of the projects in place and the Health Equity Learning Collaborative, and upcoming applications and selection for next program year. And then we have some discussions around health equity that Terry Hill will be leading. So first up, I'd like to introduce Janine Myers, our project officer for RHPTP, and she brings years of experience with hospital-based rural health improvement programs through RHPTP and also the Small Rural Hospital Transitions Project and SHIP. And I will turn it over to Janine.
Good afternoon, everyone. As Sally said, I'm the project officer for the RHPTP cooperative agreement. Just wanted to take a second to say hello to everyone and to welcome you and to thank you so much for making time to be with us on today's call. I am just really glad to be here and looking forward to the discussion. Thank you. I'll turn it back over, Sally.
Thank you, Janine. And from the center, in addition to myself, we have Terry Hill, our Senior Advisor for Rural Health Leadership and Policy, and he'll be leading our discussion today. Bethany Adams is the Program Director at the center and helps in the evaluation design. Rhonda Barkus, Program Manager for RHPTP, and she'll be providing an update on the cohorts and our summit coming up. Angie LaFlamme, Program Specialist, and kind of helps to guide our selected sites through the technical consultations, participating in those, as well as engaging eligible applicants and supporting the selected sites with implementation and follow-up calls. And Kiona Hermanson, program coordinator with the center, and she is our communication champion and who you receive the newsletters from and updates on sites, as well as all the scheduling for consultations that may be happening in your state, but also webinars and learning collaborative. So that's our team for RIP. So the RIPT purpose and goals, again, this program is designed for small rural hospitals and certified rural health clinics and strengthening that foundation for value-based care, primarily in looking at efficiency, quality, patient experience, and safety of care, and helping strengthen their potential to operate in a value-based payment system. So our goal is guiding sites that are not currently in an accountable care organization or an advanced payment model to prepare them so they are positioned to be participants in a health system focused on value. And the important role of state partners in this project is that you all help identify and refer hospital and clinics for this technical assistance and resources, whether guiding them towards webinars that we're holding, informational or learning webinars, learning collaboratives. Again, the ideal site is someone who's not in an ACO yet in your state, and maybe not financially struggling, but somewhere in the middle. And we say we look at the bell curve, and that's the 60%. So we know there's a lot of potential for this kind of additional technical assistance that provides maybe more of a targeted step than a flex or shift program could support for the quality coaching and the financial risk assessment. So another role of state partners beyond identifying referring is attending the final technical assistance sessions. And we will invite you, like Shirley, as Rhonda mentioned, we have a site in Missouri that will be inviting you to those final TA sessions on the finance and quality. And then once they are complete, to support the implementation of those action plans through your state flagship, state office, or other state value models. Maybe your state is part of the chart community transformation, or you may have an all-payer system like John from Vermont. So there might be ways that, there's efforts happening in your state that can really help this hospital or clinic engage now that they have the stronger foundation. And I'll pass it over to Rhonda for an overview on our technical assistance.
Hey, thanks, Sally. So we provide technical assistance in several different ways. One piece is the selection of up to 5 hospitals and/or clinics each year to get a very focused technical assistance. And we are currently serving cohort 2, and we will be doing applications. I'll talk about that a little bit later, but selecting our next organizations that will start around November. But these hospitals and clinics that are selected, they really get some very in-depth work, first with Stratus Health, and Carla Wang's on today, and she's going to talk a little bit about what she's seen in this current cohort. But it's really to look at the quality portion of the movement towards value-based care, and they work with those folks for several months to help move them forward in one of those areas of efficiency, quality, patient experience, or safety of care. In addition to that, the hospital and clinics all get technical assistance support from Stroudwater Associates, and it's around more of a financial operational assessment, and it's really looking at what is their readiness to participate in value-based care and what would they need to do to be more ready. In addition, they get, those 5 organizations get coaching to support the implementation of the best practices as they're really moving forward on their action plans. We also provide a learning collaborative specifically geared towards that cohort. And so Stratus and Stroudwater both weigh in on what they're seeing from the technical assistants, and all of the learning collaboratives are then designed around the needs of that cohort. We also open a learning collaborative for any other eligible hospitals or clinics for RIP, not the ones that are selected, but just others that are eligible. And that's what Carla is going to be talking about in just a moment. We have a health webinar series that Kiana will share a little bit with you about. And some of the things we've been able to do in addition this past year in this current cohort, we have been able to include with Stroudwater's work, they've been able to look at the financial impact of COVID and then really help the hospitals and clinics to look at some recommendations to help them in their own financial recovery. This year, we actually are able to, we've offered to all the cohorts or the hospitals and clinics from last year and this year to receive a health equity dashboard that is done with Stroudwater, which looks at some chronic disease issues in their community, looks at with a health equity lens, and then they will have a one-on-one session with Stroudwater to talk about what the findings were and the recommendations. In addition to that, oh, and also then next year, the health equity dashboard will be an ongoing part of the technical assistance for the 5 organizations that we support. And then the last piece that we have done this current year is a population health information technology learning and action network, which was done for us with Stratus. And the focus of that learning and action network was population health information technology. And so all of the participants were able to access some pre-prepared webinars, and then they were able to meet as a group live through Zoom to talk about the content. And then they each had an opportunity to have a one-on-one with Stratus to talk about their own challenges around population health information technology and get some support and guidance from Stratus. So this is our technical assistance overview just in general. And I'm going to pass it over to Angie now to talk a little bit about some of the early outcomes that we are seeing from from cohort 1.
Thanks, Rhonda. Yeah, so last year's cohort was made up of 2 organizations in Texas, one in Illinois and another in New Mexico. And at the end of their time with us in the RIP project, we do what are called recommendation adoption progress calls, or RAP calls for short. And these are interviews that are conducted with organizational leadership and are held at both the 6th and the 12-month post-project. And they help to support the RIP follow-up process. And the purpose is to assess the extent that a RIP small hospital or rural health clinic has adopted consultant recommended best practices and also transition strategies. And so 12-month post-project calls will include data collection on pre-project measures. But some of the early outcomes we're seeing, so we just finished our 6-month post-project calls with these 4 organizations in February of this year. Some of the early outcomes around the financial and operational improvements include expanded telehealth. An organization reported lower hospital admissions. Another is capitalizing on their coding. 2 are seeing improved cost reports. There's been some improvement in HCAP scores and also improved accounts receivable balances. And around the area of efficiency, quality, safety, and patient experience improvement, some of the early outcomes are more care coordination, improved patient discharge processes, population health planning, improved patient satisfaction. One organization is implementing a new EHR, another is expanding their EHR, and another is establishing school-based clinics and also kiosks to be able to perform telehealth services inside the schools.
Thanks, Angie. And as Angie said, this was just the kind of the story of the first 6 months. And at 12 months, she will ask those same questions and get the rest of the story and collect the measurable data at that point as well. Anything else on the outcomes, Angie?
Nope, that's it.
Okay, all right, thank you. So then to talk a little bit about RHPT, the cohort 2. So we actually began with five hospitals and clinics combined. So hospitals can either apply alone, or a clinic can apply alone, or a hospital and clinic can apply together, or a hospital and several clinics can apply together. And this past year was still really a transitional year in a lot of ways. There was a lot of interest in the project. People were applying, and then there was another wave of COVID. And so there's been a lot of starts and stops. But this year, the three programs that have continued with us are Electra Memorial Hospital in Texas, Golden Valley Memorial Healthcare in Clinton, Missouri, and Cotoda Prairie Healthcare System in Sisseton, South Dakota. In addition, here the list of the 5, and so we did have 2 that needed to drop out as just about 2 or 3 months into the project. And again, and one was Dollar Memorial Healthcare in Montana, and then Sierra Vista Hospital and Clinic in New Mexico. And both of those, as you all can imagine, it was due to the shortage in workforce. That the leadership teams were wearing several hats. They were often working without a director of quality. The CEO was also helping to scrub floors. And so it really just was not a good time for them. But both hospitals said that they do plan to join us again in the next cohort year. So we're glad about that. And we were very excited because there are some strong hospitals there. All right, and with this, I'm going to hand this over to Carla Wang to talk about the work that Stratus has been doing with us. Carla?
Thanks, Rhonda. So it's been really a pleasure to get to dive in quite deeply with the 3 participating organizations in this cohort. And although they all do have hospitals across the board, we're actually also talking more broadly about their hospitals and the interaction with their clinics. So it does encompass sort of both the hospitals and the clinics as we're working through them on sort of a deep dive in terms of quality. So the structure for this is that each of the participating organizations select a focus area of those. You've kind of heard it listed a couple of times: patient experience, general sort of quality improvement, infrastructure, care coordination, or patient safety. So we ask them to sort of pick a track. And then we have an aligned organizational assessment on each of those areas, depending on what they select, recognizing that all of those things also intersect. They're not standalone, but we try to focus in at that point. And then based on the organizational assessment, we work with them to target opportunities for improvement. We help develop SMART goals and work plans, action steps through the process. And we end up with about 6 or so months where we're actually meeting with them on a very regular basis. So usually about every 2 weeks. Sometimes it gets stretched out a little farther than that. So our role at that point is really to help them kind of prioritize, target, develop goals and work plans. And then we provide a lot of support, identifying resources, helping them problem solve, talking through what things might look like. We sometimes do some direct training for them. Sometimes we'll do some direct facilitation of process mapping. We also really do try to connect folks with other resources where appropriate. So as I see, I actually know several of you on the phone today. So because we're in the quality improvement space, you know, if we know that the Flex program is doing something, we try to make that connection. We try to align as appropriate with what's happening if they're part of the quality improvement innovation or HQuick hospital quality improvement contractor work. We try to make those connections and alignment so that we're supportive and aligned versus duplicative and separate. So really trying to help connect the dots across that work. So after I kind of can view the work that we get to do with these folks as sort of an intensive shot in the arm. It's a lot of infrastructure components and helping them think through how as a team they kind of structure and support this work. And we wrap up when we work with them, we'll wrap up with this current group in August. They walk away with a full set of an action plan of what they're going to be doing over the coming months. And we try to align and make sure that they're aware of what types of resources available in those areas. So for the current group, we have a couple things going on. One of the organizations is really focused on how do they better embed quality improvement into their organizational culture. And as part of that discussion, we've had a lot of conversations around employee engagement, employee wellness, resilience, all those challenges that are happening in a lot of workforce environments, and kind of connecting the dots between how they actually support and embed quality improvement into part of that culture that's supportive for their workforce and their patients in the community they serve. We have another organization that really wanted to dig in deeply on their patient experience results, and through their assessment recognized that although they actually do not too bad on their scores and they have had a focus on it organizationally, they actually didn't have a lot of the infrastructure built in to their kind of underlying processes. So they like to say that they provide excellent care in everything they do, but that wasn't sort of built into job descriptions or onboarding or training, or kind of thinking about how do you ensure that you have the infrastructure in place to get towards those goals that you want. And then the third organization is really doing kind of, I would call, a refresh and reimagining of their discharge planning process. So they have processes in place. I think lots of the pieces and parts happen, but you know, it's been a rough couple of years. And it's kind of time to pause and take another look at what that looks like. And then they're working through that to also more broadly incorporate some care coordination strategies and support. So how do we make sure that this is more broadly connected and they're going to be in a good situation to then roll into more of an outpatient care coordination program, with starting with kind of building that infrastructure on their inpatient side. So that's sort of the big picture summary of the three that we're working with this year. We've also had the privilege of supporting the Eligible Learning Collaborative for this year. We are focused on health equity. I think there's 19 organizations signed up, but I'm looking for Kiona, who I don't see. There she is, she's nodding at me. We're doing it monthly. We started with a focus on implicit bias and just some definitions and discussions around what is equity, what are health disparities, how do we start to think about it and talk about it. All of the participants then completed, again, an organizational assessment. It wasn't something they submitted to us. It was just something for them to think through, kind of what are sort of the key components of how you move forward and start to think through what this looks like as an organization. We had that discussion with them in May. And then now the last two sessions are going to be digging in a little bit more deeply on sort of how do you think about leadership, either implied or situational. How do you sort of raise this across your organization? And how, I think the last session will likely end up with kind of how do you start to dig into some of your data pieces for this. We're also trying to highlight and connect the dots in terms of some of the things that CMS is coming out with or potentially coming out with in the proposed rule. There's some measurement components that are coming out that will focus on health equity. So trying to help people be prepared and connect the dots for those as well. So that's where we're at with those two pieces.
Thanks, Carla. So I'm going to hand it over to Kiana to talk a little bit about the webinars from this year.
Thank you, Rhonda. So our webinars this year, we had scheduled 8 help webinars from February ranging through August. The topics of the webinars we took from what we were seeing was needed from last year's cohort, plus a combination of what we were also through the discussions of those who have applied and participating in this year's cohort, as well as the satisfaction assessments from last year and the topics that they had recommended that they were looking for more information on. We kicked off this year with a 2-part series with Dr. Kleberg providing more guidance on ACOs. He presented in February and March. And then in April, we had Dr. Alana Knudsen with a follow-up on social determinants of health, more specifically in the value-based payment models during this COVID-19 period. And that was a follow-up from last year's presentation. We had great attendance for both of those. And then we focused again, building off of the resilience topic. So we had Stratus Health share more about building resilience and seeking organizational resilience of a spin of what others have been sharing around resilience. All of those playbacks, the links are available, but you are welcome to look back at the playbacks. But then we have upcoming webinars. No Source series is kicking off in June, so June, July, and August. They will be speaking around transition to value. And then to close this year's help webinars, Caravan will be presenting around improving quality outcomes with ACOs and 340B. You're welcome to register to attend our upcoming help webinars, or even encourage those who you feel will be may benefit from the knowledge shared within those. We encourage you to share the opportunities as well as attend them yourselves. But that is what we have for this year's help webinars.
Thanks, Kiana. All right, so again, our application is live for any hospitals, clinics, or hospital clinics together that would want to apply for that more intense technical assistance and be chosen for our 3rd cohort year. Those 5 organizations, and again, they will receive that more intense work with Stroudwater and Stratus. So we have simplified our application. And what we will do is, it's a very basic application. We'll only take a few minutes for the hospital or clinic to fill out. And then we actually will schedule a one-on-one Zoom meeting with them to dig in a little bit deeper to look at what they're hoping for from the project and some of their strengths that they're bringing into it. So it's more of an interview process. And the applications will be open through Friday, September 30th. So we really would appreciate your help. Like Sally had said earlier, please feel free to share this with clinics and hospitals that you're aware of that might be interested and eligible. For the hospital, it would be 49 beds or fewer. And then of course, rural, and the same, of course, for the rural health clinics, and they would need to be certified clinics. And then the last thing I wanted to share with you, we are very excited that this month we have a Health Equity and Quality Summit coming up, and just really looking at what the hospital and the clinic's role is in addressing health equity in the community, and really helping them to think through how to improve the quality of the clinical care as they move forward to prepare for value-based care, and how that can impact their healthcare costs and population health. So we will be convening some nationally recognized subject matter experts across the country. We will be doing most of the work virtually with a little bit of pre-work that folks are doing. And the focus is really to look at the association between rural health equity and healthcare cost and quality. And what are the drivers that can help move rural health quality forward, rural health equity forward. look at what are the barriers that are preventing health equity in the rural communities, and then to identify some best practices and innovative models. And we're so excited because we have subject matter experts from so many different areas, whether it's clinical quality, whether it's specifically health equity, whether it is CEOs of hospitals, directors of EMS who have worked a lot with health equity in their communities. We have somebody from Hospital Association, State Office, somebody from HRSA. So we just have a really, really nice group of SMEs. From that, we will be creating a report that will share the findings of this. But in addition, the writer for this will be doing some additional pulling different resources, and so it'll include the work that we're doing in the summit, but also more of a literature review on some of the other pieces as well to support what we're talking about in the summit. And then our focus question is, what are the high impact practices in value-based care and payment system that will fuel rural health equity? So how can we really leverage value-based care and payment systems to really move rural health equity forward? So we're very, very excited about that. And so watch for the report that will be coming out, and we will also have a video that will accompany that. And so before we get into the discussion, I just wanted to check. I see some chats, but I'm not able to really see. Is there anything, Kiana, we need to pause for? Were there any questions or anything?
There was just a question regarding the application process. And I had just shared that we have been promoting it on an ongoing basis, but I'm happy to share in our follow-up email, we will share notes from today's call as well as the playback, and I can share language as well as how to apply and who you can share that with to promote it for those within your state as well.
Thanks, Kiana. Yes, and we hope that we're really fingers crossed that things may settle down just a bit, and folks will be able to have a little bit more bandwidth to be able to take advantage of the project.
I would really encourage you to reach out. If you have a few folks that you think might be eligible, really encourage you to reach out to them directly. They may or may not see it through other channels.
That's true. Thanks, Carla, for that reminder. All right. So with that, I will go ahead and turn it over to Terry Hill, who will facilitate just some discussion around a few questions. Terry?
Thank you, Rhonda. And it's great to see old friends here, folks we've worked with for years, et cetera. And we have kind of the right folks at the table here. Rhonda mentioned that we're going to hold a summit meeting, and I have some feelings about the fact that movement into value-based payments may very well be very good for health equity. But we really wanted to start a discussion in the summit, and even before that, at this meeting, to get some thoughts from you in terms of what are the kind of barriers to health equity as you're seeing it, both from a financial standpoint and from a value-based care standpoint. I know that John Olson in Vermont is working with a global budget model that I really appreciate his perspective on some of this. Pat Scow has been one of the early pioneers and highest achievers in terms of accountable care organizations as well. And she commented, for example, that the state of Illinois is starting to require equity statements in applications. And what I can tell you is that the new ACO model, which is REACH, also requires an equity plan before CMS will approve any of these new ACO types. So let's get started. And again, let's take a look at what's standing in our way here as we're looking to improve equity from multiple dimensions here. It's racial equity, it's location, rural, et cetera. What are some of the financial barriers out there? And also, if you you can comment on, are we seeing any value-based care barriers that you'd want to discuss? Pat, let's start with you. Anything you're
when
seeing
you asked me
here?
that question, I'm thinking financial barriers. Probably is that the barriers would be transportation and poverty in some of our areas, and there aren't a lot of resources for that. You know, I think treating people the same and all that stuff, that's not the issue. And then we don't, you know, in our rural areas, we continually do not have the diversity, you know, at least in Illinois, in many of the areas. But I think the financial barriers really are transportation and getting people to and from places for care, and you know, even having a smartphone for older people and things like that. And then you know, supportive resources. That's all I can think of, you know, at this.
And so what I'm hearing you say, Pat, is that perhaps if they can't afford or they don't have access to, or maybe their broadband is limited, that would be something that might also serve as a barrier.
Yeah, it's kind of an equity, and you know, we're seeing more and more of our rural counties poorer and less resources. And you would think that in today's society you wouldn't have people that don't have running water and things like that, but we still do have that, and it breaks my heart.
Yeah, absolutely. Other thoughts? John, since I already mentioned you in Vermont, anything that you could add to that, particularly as you're looking at you know, your global budget model out there? Is there anything kind of standing in your way that has to do with either the value-based model itself or finances?
Yeah, thanks. Hi, everyone. We, you know, not surprising, because of COVID, we put a lot of the sustainability planning that we were working on in 2018 and 19 on hold, and just, you know, went into survival and a bit of crisis mode, as you can imagine and are familiar with. So I was just quickly looking back at any of the recent hospital budget guidance, and I don't see any specific things about global budgets, but that's, you know, just looking at that, I don't follow it that close, but I think that we're not quite there yet. So I think we're still inching our way there. Okay. We've had several conversations with national folks, and, you know, even Tom Morris from the Federal Office of Health, Rural Health Policy. And I said, yeah, it was nice for 7 or 8 years to be on the leading edge of some of this work, but right now it really feels like the bleeding edge, and folks are struggling to figure out, you know, what are their next steps, what's safe, and how do they keep, you know, their operations going. So that has been a tremendous challenge for, you know, hospitals everywhere, and there's, you know, a good amount of push back and forth from all sectors, from our statewide regulatory healthcare board, the Green Mountain Care Board, the administration, and the legislature, and hospitals. So it's just really, people, I think, are still, they're definitely committed to the idea of value-based care. We've got long history, 20+ years of, you know, case management and self-management and care coordination and things like that. But these next steps are challenging. So one of the reasons I'm tuning in today to find out what I can offer and talk my hospitals into in the RHPTP program.
Are you finding, John, that, you know, similar to some of the hospitals that we've been working with too, in particular in this go round, that the crisis in terms of workforce has been kind of limiting interest in anything other than just survival here? I kind of heard a little bit of that.
Yeah, that's a big part of it. We get a almost daily report on, you know, number of beds available and such, and, you know, that was really important during the height of the pandemic, or the several heights. But now we're reporting, continue with that, but also talk about sort of the level of risk that the hospitals are facing for workforce shortage, kind of a, you know, I think it's like yellow and orange and red level, just for staffing. And they're all talking about, you know, the cost of traveling nurses and such. So it's a difficult sell at this point. I wish I had a few more zeros to offer to all of my hospitals for my grants, but.
Andy, since we're in kind of the New England setting, anything you want to add to that? Anything you're seeing out there that's kind of standing in our way to equity?
Sure. And thanks for letting me join today. I just started last week as the executive director at the New England Rural Health Association. So I thought I'd jump into the deep end with both feet here. And just as for everybody out there, there's sometimes some confusion, but New England is the 6 states. So Connecticut, Rhode Island, Massachusetts, Vermont, New Hampshire, and Maine are the states involved. The workforce thing is definitely huge. Organizations find they just don't have the bandwidth and the human capital to do one more thing. One of the things that I think can be a challenge is as hospitals and rural health clinics move towards value-based payment, is the ACO or ACOs that they're members of. In some cases, the ACOs are very rural specific and rural aware, but sometimes you get, there's not an option. And this, especially in New England, this can happen, particularly because we're such a patchwork area where there are rural areas that are actually not terribly far removed geographically from some urban areas, but nevertheless they're rural. But sometimes it's hard to for them to join an ACO, like a Medicaid ACO, that really has knowledge of or cares much about rural, because so many of their covered lives come from much larger markets. So if you don't have that, an ACO that really thinks about some of the differentials between everybody else, urban, suburban, et cetera, and what's going on in rural, it's hard to, it can be hard for some of those smaller provider organizations to figure out what they're going to do. It's enough of a culture shock to have to try to move to value-based care, figure out what the risk contracts are going to look like, and so on. But if you're dealing with an organization that really is looking, maybe multi-state or, even in some cases across the country almost, it's kind of hard for them to get much traction. And especially when, if they're developing quality models that aren't based on rural populations, that can be problematic too. I'd also echo the thoughts expressed about social determinants of health. Those are, I think, huge barriers from the point of view of consumers and so on. So certainly things like broadband and cell service and so on. I would point out that, again, New England's a little bit, has somewhat of a different environment than some of the states, in that a number of our rural areas have populations that are in areas that may be second home or vacation areas. And the populations, in fact, are going to be, may well be people who are migrant or immigrant workforce from offshore, who are working on the fishing fleets, who are blowing snow at the ski areas, who are working on the farms, who are working in the tourism and hospitality industries. But they're trying to live in an area where the housing prices may be high because of second home ownership and vacations and so on. So there are a number of kind of specific challenges that we can face that are definitely challenging as everybody starts to, scratches their head and figure out what's life going to look like in a value-based world.
Yeah. And Terry, I'll add to a couple of things you had asked about, sort of health equity, and also I'll say a little bit more about the budget process. Some of you may know that we're a highly regulated healthcare state. So all of the hospitals have to have their budgets approved annually, including caps on increases. That's all before the Green Mountain Care Board. And they've released their guidance on the budgets for FY23. And one of the sections that they are required to talk about, in addition to finances and such, any change of services, is equity. To talk about that explicitly, and wait times and any other risks or opportunities they're identifying. And also there's an entire section, probably, could be 10 slides on how is it where they are in their value to care process. So we'll hear more about that over the summer, and then there'll be votes to start October 1.
Terrific. Let's move to the next slide. Let's talk about which I find kind of an exciting conversation here. Let's talk about, next slide, please.
Sorry, I'm trying to get it to go, Terry.
That's okay. I've got it right here. So what are the financial or value-based care drivers specific to rural that can help advance health equity? And that's kind of what we're really going to be exploring in some depth as we're putting our summit meeting together. In other words, what is it about value-based care and those sorts of drivers, or what is it about the changing financials payment system that might be good for the social indicators of health, or helping to drive or advance health equity?
So
I did put
Terry,
it in the chat box. Sorry.
I would just say, I think we're hearing a couple examples of that from Pat and John, just in terms of, in Illinois, they're asking hospitals to apply for grants if they have a health equity statement. And in Vermont, you have to kind of say how you're addressing health equity as part of your hospital budget process. And so I think we're going to see continued focus there. But I think one of the challenges, it's not really a financial or value based, is just taking those like maybe 8 steps back and starting to, particularly for hospitals and communities that maybe don't have a lot of racial or ethnic diversity, that there's more to equity than racial and ethnic diversity. I think a lot of people jump straight there.
Yeah.
I mean, I grew up in North Dakota. The diversity, I would say, in the community I grew up was, whether or not you were Lutheran, Methodist, or Catholic. So, but there is a lot of diversity, and there were definitely equity issues in terms of, ability or finances or education, or so just trying to help. So not to minimize, because the racial and ethnic issues and disparities are huge and need to be a focus, but also taking those 2 steps back and helping, especially some of those organizations who do live are in communities that maybe don't have as much of that type of diversity, of what diversity is and what does it look like, and how do we start to put our arms around looking at data and information in different ways to identify where our gaps are, racial and ethnic or otherwise.
Thanks, Carla. Shirley, what do you think? Tell me a little bit about your perspectives on this from a Missouri standpoint.
Okay, and Terry and everyone, hi, I'm Shirley.
Hi.
I am the new rural health coordinator under Barbara Mendel, also working with Tiffany. I just started this job, 2 weeks max. So let's keep that in mind. I just finished my MPH at MU. So I'm pretty fresh to it.
Yeah, we're glad to have you here.
Thank you. Before I was started as a rural health coordinator, I was working on the CDC Health Disparities Grant. So we did talk a lot about equity specifically, and we've contracted with mostly LPHAs and community-based organizations focusing on equity. But I've been going to the MRHA listening tours, is what they're calling it in our town. Well, in our state, I guess, not our town. I call everything a town because I'm from rural Missouri. So everything's a town to me. We're asking them, what are the barriers that you are facing as LPHAs, as rural clinics, as rural healthcare providers? And a lot of them are the exact same. It's transportation, it's staffing, it's appropriate funding. Something interesting that I'm looking at, not because I have an idea, because I don't, is like the dichotomy between like their HPSA scores and their available funds, and how we want them to lower their scores and they want to not lower their scores. And I'm like, wow, this is really interesting dynamic to be having, sort of opposing forces in this way, but all of the same issues over and over. I went to the National Health Convention. They talked about, like, when you're talking about quality measurements and how a lot of times quality measurements are not geared toward rural organizations because, say your quality measure is 90% of your, surveys have to be 100%. And if you only have 2 surveys in a rural hospital and one of them fails you, you have failed your quality measurement. Like, there seems to be less focus on how rural organizations actually work in that way, but they are facing higher poverty. They are facing less access. They are facing, so I think I don't have anything new to add to it. I'm just trying to catch up to speed and see how I can be helpful for Missouri. So I'm listening carefully.
Right, Shirley. And again, it's really nice to have you with us. Pat, you've been running an ACO now for many years. Have you seen any benefits from an equity standpoint? I'd really appreciate your perspective on this. Pat, I'm
sorry, I had somebody called me. I apologize.
Oh, okay.
Just a second, they won't get off the call here. What I wanted to say was from health equity standpoint, financial drivers, is that we're really not seeing so much the health equity in value-based care discussions, but we're seeing social determinants of health. We're seeing it framed differently. So we don't see that health equity lens, but we see social determinants of health and how each group will relate to it. The second thing, and I apologize, I have to get off, but the other thing I'm seeing merging is community health needs assessment. They are just, it's really coming through health equity. People are looking at it. They've broadened the definition, as Carla indicated. We've moved away from the racial and ethnicity to really the broad perspective, and really thinking more about social determinants of health as opposed to our populations, as opposed to that other framework. So,
yeah. One of the things that I'm seeing is because of the emphasis on social equity, equity and racial equity, et cetera, we're seeing organizations where they're never really interested in rural health before. I'm just sensing a kind of a renaissance in companies that had never done anything saying, hey, tell us about rural health. What's a rural hospital like, sort of a thing. So.
And I agree. And I think we bring a different perspective, and I think we can't hold ourselves short with that. We have to be able to broaden that lens. And I think you start with your community advisory and your community groups and having them think about the populations you can't reach, and then about equity. So anyway, I'm sorry. I've been beeped a couple times. I have to leave. I apologize. Good conversation and nice to see everybody.
Thanks, Pat, for sticking around. We're almost done anyway, so you stayed to the end. Yeah, it's fine. The last slide basically, just basically ask, is there anything really going on out there in your states that you'd want to talk about or discuss? Are there any health equity initiatives emerging? I think we've heard a couple of them already, that the state of Illinois is requiring putting in an equity statement or an equity plan. I already mentioned that the new ACOs are going to have an equity plan, not just a statement, but a whole plan in that regard. Anything else that anyone else would share? I think John said something about this as well, but any kind of final thoughts on something happening you might be excited about, or something being planned? Well, I appreciate the discussion. We're close to the end already here. So I really want to thank everybody for kind of being part of this discussion. And it's been great to meet both Shirley and Andy, as new folks coming in. Shirley, in particular, besides this particular program, we have a huge program in the Mississippi Delta that we'd want to be able to talk to you about and get you involved in as well.
Is it the email by Suzanne Snyder, who was just talking about their cohort?
No, it'll be coming from our center, Shirley. We have hospitals that we're working with in Missouri specifically. But we'll talk about that at a later time. We're running out of time here. But do contact us if you want more information. You can call it. You can contact us directly here at RIP, or, contact task. So we can, the task, the Technical Assistance and Services Center, which is basically there to support you, especially as a new coordinator here. So, Rhonda, I'm going to turn it over to you or Sally. Sally, maybe? You want final comments, Sally?
Yeah, Sally.
Yeah. Thanks, Terry. Yep, and actually Suzanne Snyder is the project officer from RHP shortly for the Delta program.
Yep.
So that is her. So that is who I needed to. Okay, thank you so much. I was telling Kiana in the Kiana in the chat that I was like, everything's sort of freeform jazz in my brain right now. It's all of these organizations, all of these acronyms, which one's which. I'm trying to get there.
Well, we always say there's no wrong door, no wrong chat box, so don't worry.
Okay. Thank you.
Yeah, we work closely with the states and with the Federal Office of Rural Health Policy. But yeah, so thank you, state partners, for joining us today for our mid-year update on the RHPT program. So we're happy to share where we're at now with the cohort of hospitals and clinics and getting ready for the new year coming forward. Did put the website address as well as the email in there. And if you have specific sites that you feel might be good candidates, where there's, the website has a nice overview of the FAQs and the type of simple application, but if there's specific components, or if like us to kind of frame something that you can put in a newsletter, are happy to do that from some of our other outreach messages. So thank you all for joining today, and we'll share out the slides and recording with you as well. And have a great day.
Thanks, everybody.